I see we're moving even earlier in the disease space. And how do you feel about FGF earlier? I know there's different frequencies where it's detected across disease states.
I believe it's detected in up to 70% basically of patients who have superficial bladder cancer. I think it will naturally kind of evolve into a trial in that space. The questions really become toxicity versus benefit, as it will with all of these therapies earlier on, and being able to avoid radical cystectomy in that high-risk patient population. I think that data is compelling that you publish, and I think that the responses are continue to show similar responses in a superficial population with less toxicity potentially, then it would be a very reasonable approach in patients with high-risk non-muscle invasive disease.
Okay. So maybe a role in muscle invasive disease. How about in urothelial tumors of different sites? Do you see any differences in mutation frequency, even in metastatic settings? Betsy?
Different sites like upper tract versus...
Upper tract versus lower tract.
I think there have been a lot of studies sort of looking at that. They're powered somewhat, but not comprehensively in my mind. I think while there may be a propensity to a different mutational pattern in one versus the other, we're still in the clinic faced with defining that particular patient in front of us and determining what makes the most sense.
There's actually an interesting adjuvant study that's led by Monty Paul and others looking at one of the FGFR inhibitors, infigratinib, for upper tract disease. And so the thought is, if we're seeing more FGFR mutations in the upper tract, then maybe these patients benefit more from adjuvant therapy early on as well. So that is an ongoing phase 3, I think it's randomized to placebo trial for patients with FGFR mutated or translocated upper tract urothelials.